Can you please check whether the lesson is being transmitted? So, we'll start from the point that we finished our cases in our last lesson. And remember that it was a case of a massive pulmonary embolism which caused the death of the patient. Now, we can see in the image the histologic structure of the thrombus. So, what are these lines here? Have a look. What are these lines? Which part of blood is this? You see there are some red lines and some pale pink lines. So, the red lines are red blood cells, and the other lines are fibrin, platelets. So this linear structure of the thrombus verifies that it was formed while the blood circulated above the endothelium. And it is important to see this because when a man dies, some clots form post-mortem. So they are not specific. This is not the case here because we see these lines in the thrombus called Zahn lines, lines of Zahn. So this was a true clot, a true thrombus. And the patient most probably suffered from systemic lupus erythematosus with the complication of antiphospholipid syndrome, which increases the tendency of forming thrombi. So, if you have a patient with systemic lupus erythematosus and you suspect that this complication has occurred, you have to complement your therapy with anticoagulative factors. It's not enough to treat the lupus. You have to give extra medication in such patients. Next, have a look at this kidney. It is obvious that there is a well-demarcated region. How does it look like? Yes. White, it's pale. So it's an area of coagulative necrosis which happened after an abrupt occlusion of which vessel? Which stem from the celiac artery gives blood to the kidneys? The renal artery. So either there was an atherosclerosis developing in the renal artery and became bigger and bigger and bigger, and it occluded the lumen, but this is not so common because when an atheroma increases in size, this is a gradual procedure. Here, something abrupt, something acute happened. So, most probably, what caused the infarction of the renal artery? What do you think? Let's have a look at the history. It is a man who had metastatic pancreatic cancer, and in such end-stage disease of cancer patients, as a paraneoplastic syndrome, the blood makes thrombi, all right? It's some sort, if you have a terminal, a cancer patient of a terminal stage, his blood most often makes clots. So this is quite something to think about. And have a look how the renal infarct presented. Flank pain and hematuria. If you have these symptoms, the first you think is of a colic pain of the kidney. However, this is not the case here. There is no stone moving through the ureter and causing muscle spasm. That's what causes the pain in this case, in the case of colic pain. No, it's not the case here. What has happened? An embolus blocked, occluded a part of the renal artery, so the part of the kidney parenchyma which was taking blood from this artery had coagulative necrosis. And since renal arteries are terminal arteries, there was no way that other blood would come there from any other source. That's why the infarct you see here is pale and not hemorrhagic, because renal arteries are terminal arteries. No adjacent circulation, no dual circulation, as we said last time. Yes? No, it isn't. No. But it justifies the symptoms. It's not fatal, no. However, I think the patient had, you see, a venous thrombosis without valve pathology. What does this mean? If the embolus came from the heart, where would it probably be formed so that it goes and occludes the renal artery? In which part of the heart is it logical that the? Yes, to pass through the aortic valve, so in the left ventricle. In the left ventricle. However, there is a history of deep venous thrombosis. This does not make sense at the first time. Why? Because if we have a deep vein thrombosis in the lower extremities and a thrombus is formed, where will it go? It will go to the inferior vena cava, and it will go to the right heart. Is there a possibility that such a thrombus pass to the other side of the heart? Yes. How can this be justified? To have a thrombus from the deep veins of the leg, the thrombus leaves the area where it was formed and follows the venous circulation. It goes to the right atrium, the right ventricle, and it does not pass in the lung artery to make an embolism of the lung, but it passes to the left ventricle. What must there be? A defect. There is a defect between the two ventricles, the septum, and so it can pass. This is paradoxical, all right? This is paradoxical embolism. And most common such cases are related to an increase in the pressures of the right part of the heart, known as Eisenmenger physiology. It's something that means there is an increase in the lung circulation, a pulmonary hypertension, in other words, and it helps the thrombi pass through such defects in the septum between the two ventricles. All right. So this is a renal infarct, and you see how pale and wedge-shaped it is. And there is a zone, you see here, there is a zone of increased vascularity in the border of the infarct. Yes?
Why does increased pulmonary circulation better?
The increase in the pulmonary hypertension may be justified by various circumstances. For example, as we'll see in our cases of respiratory system, you have a chronic lung disease of obstructive pathology, such as emphysema. It increases the pressure. That means that the right heart is stressed to send blood in the pulmonary circulation, and thus it becomes hypertrophied, the right ventricle. So, in these cases, it is difficult to send blood through the pulmonary artery, And if there is a defect in the septal, most easily something does not go to the lung, but it passes to the left ventricle and goes peripherally and causes all this. This is paradoxical, of course. It's an exception. It's an exception.
So it prefers to go through the...
Through the defect in the septal, under condition that there is one. Yeah. Okay? So this is called Eisenmenger physiology, an increase in the pressure in the right part of the heart. Yes, please.
So the blood was formed between the left and the right atria, and then...
Yes, it came with the venous circulation, and the lower cava, the inferior cava, came to the right atrium. It passed in the right ventricle. However, it did not embolize the pulmonary artery, but passed to the left ventricle and went down the aorta and occluded the renal artery. You remember what we saw, the mesentery artery infarct? In that case, the clot would go to the mesentery artery. Yes?
Couldn't the embolus travel from the right atrium to the left atrium?
It's not so often in case that there was a defect between the two atrium.
In histology, that 25% of the population has foramen.
It has to do with the difference of pressure between the two cavities. Yes. This is a determining factor where it goes to, where the embolus goes to. If there is pulmonary hypertension, it does not help to go to the lung, to the pulmonary artery. It passes to the other. It passes to the left side of the heart. In our next image, look, this is the aorta. It has 3 cusps, as it should have. However, you can see some abnormalities raising on the cusp. These appear like vegetations, and you could think that it's of infective origin. However, this is not the only case in which vegetations develop in the valves. In this patient, we see that this is a patient with a brain tumor, a deep vein thrombosis in his lower extremities, and he died suddenly of pulmonary thromboembolism. And we also found splenic and renal infarctions, such as the one we just saw, with the aortic valve lesions, and no other cardiac findings. So what is the diagnosis? In very severe diseases, when there is very severe disease, the patient, these cusps have come some bland vegetations, not of infectious origin, non-bacterial. However, since there are vegetations in the cusps of the aortic valve, what can they form? What can they form? They can be detached and make emboli. Yeah. And this justifies the emboli found in the spleen and the kidney. All right? Yes, please.
What do you mean by vegetation?
But it's what grows exophytically from the valve. As the blood passes, it breaks it. So it becomes an embolus. However, the patient died not of these infarctions. He died of pulmonary thromboembolism. Why? Because a thrombus from his deep veins in the lower leg was detached and reached the right part of the heart, and of course, as it is logically expected, it occluded acutely, abruptly, the pulmonary artery. So the bronchial arteries could not contribute enough blood so that the necrosis was not did not happen, and this caused the fatal pulmonary embolism of this patient, which is a common death reason for death in many cancer patients, because their blood makes thrombi. That's why when you have a cancer patient, you have some anticoagulant therapy in order to prevent such embolisms. Next, have a look here. This is an autopsy specimen with a card of a middle-aged man who had a 4-hour history of chest pain radiated to his neck with unusual sweating and dyspnea. So this, of course, you suspect that there is a myocardial infarct. So in order to be sure, you look for two sort of enzymes biochemically. Which are they? It's the troponin 1 and the creatine phosphokinase. The latter increases within the first day of the myocardial infarct. The other, the former, troponin 1, increases and stays a bit more in high levels in the blood. So, from a biochemical point of view, if you suspect from the clinical symptoms that a myocardial infarct has occurred, you order these two enzymes. CKMB, the specific isoenzyme of creatine phosphokinase, because in any cases of muscle damage, in any case, if you hurt yourself and you have a muscle damage, it may increase. But you look for this particular isoenzyme in the serum. So, which is the most common cause of the infarct? An abrupt occlusion of some coronary artery giving blood to the respective part of the left heart, most often, that becomes necrotic. And the most common mechanism is the abrupt alteration of a pre-existing atheromatic plaque, which breaks, and the endothelial lining the plaque is eroded, so a clot is formed, and it either blocks the coronary artery in that place in which it was formed, or it leaves this place and goes further in the coronary circulation, becoming an embolus. In any case, a part of the heart has no blood, and this is not a chronic procedure, because if coronary arteries are stenotic, of course there is some sort of impairment in the supply of the myocardium, and this causes hypertrophy of the myocardium. If we have hypoperfusion on a chronic basis, that's something different. It adapts to this lower blood that comes to it by becoming hypertrophic, so that it can contract and send the blood away from the heart. In this case, something acutely happens, so there is no way of adaptation, and the muscle fibers become necrotic. And after some hours, you can see all this part of the ventricle, the left ventricle, with this macroscopic image to be not functional. And of course, as far as blood thrombi are concerned, there are some endothelial factors that either help the thrombus to form or impede the thrombus to form. And this imbalance between these two functions of the endothelial cells, in the present case, led to a thrombus formation, and we had this fatal infarct. And of course, we'll see today the complications of the myocardial infarct, which can cause the death of the patient. However, all arteries are not blocked abruptly exclusively by thrombi. It is the most common cause of arteries obstruction, but not the only one. Not the only one. Can you see the histology here in this vesicle? And how can you recognize that it is a vesicle since you see no what? What is there that has disappeared and is compatible with the infarct formation? Is this a vessel? A vessel? What's missing? What's missing from this vessel? There is no lumen, of course. So since the lumen was occluded, the vessel does no longer send blood to the tissues. But here, the cause of occlusion is no thrombus, like the previous case. What cells are there surrounding the occluded lumen? You see, it's a patient with systemic lupus erythematosus. This is an autoimmune disease that causes what? Vasculitis. So, arteries are occluded not only by thrombi, as most often are, but by autoimmune disorders which bring many cells in the vessel wall, and the cells with their lymphokines, because since it is an autoimmune disorder, which cells go there? Which white blood cells go there? It is autoimmune, systemic lupus erythematosus. So, which cells? Lymphocytes. And they cause this abrupt obstruction of the artery lumen. So, luminal thrombosis. It could be the antiphospholipoid syndrome, which we have already talked with forming of thrombi. And here is the mechanism of coagulation cascade, the extrinsic. Now have a look. In this autopsy specimen, yes, please.
In the previous slide that is about vasculitis, the primary cells are the lymphocytes. Don't we also have a lot of neutrophils there due to the type 3 hypersensitivity reaction from complement?
The main white blood cell population is lymphocytes. However, if some tissue elements are destroyed, the presence of polymorphonuclear neutrophils is expected. In many cases of vasculitis, when we have the specific type of necrosis affecting vessels with vasculitis, which is fibrinoid necrosis, in this case, we have neutrophils. However, we do not have neutrophils with normal nuclei. They are fragmented. And these are called nuclear dust. So, in many vasculitis, we see either a lymphocytic population invading the vessel walls, or fibrinoid necrosis, which looks like fibrin. It's very bright in the staining, the normal staining, and in Masson stain, it stains red, very deep purple, and we have the nuclear dust of neutrophils.
So what type of hypersensitivity reaction is vasculitis from systemic lupus erythematosus?
The systemic lupus erythematosus syndrome is a form of vasculitis. That's why it affects all tissues. It affects joints. It affects the heart. Why? Because it affects the vessels, the arteries. So it impedes their blood supply. This, however, is another case of microhemorrhages in the white cortex of the brain, and this patient has a history of severe trauma, a motorcycle accident, for example. So, if he broke some long bones on the leg, what could form the emboli that pass from the circulation and go to the brain and cause all these small hemorrhages, because these are very small emboli who go there, so that means that somehow they've reached the left side of the heart and went up the carotid arteries and went there to the brain. And when they embolize these small vessels, they become necrotic, so we have microhemorrhages called, do you know how these are called? These are very dot-like hemorrhages are called petechiae. Petechiae. So, what do you expect to be the nature of the emboli in this patient? What do you expect? What can go? If you break a long bone, what is there to come in the cells and become a embolus? In the present case, in the brain blood supply. What? What is there in the long bones? What is there? The bone marrow with fat tissue. So this is fat embolism. To be more precise, it's bone marrow, not only fat. And bone marrow cells, they form emboli, and we have this petechiae in the as an autopsy finding in this case. Yes, what you see in the brain. Due to the multiple microemboli which have occluded the small parts of the Willis cycle of blood supply. What has entered the right atrium in this image? You see that a part of the right atrium is dark. This is not normal because it should contain blood. So what entered the right atrium? And you see here, as you see the arrowhead and it shows. Yes?
Air.
Air. Yes, because if somebody stabbed the patient, the vein was cut, air came to the vein, so it passed to the right atrium. This is air embolism and is analogous to the decompressor syndrome of divers. When they go up very quickly, they have to come up to the surface not very quickly because air will form in their vessels and will cause embolism. This is air, an air embolus here. Here, all these petechiae, like we saw in the brain, are microhemorrhages formed from a systemic disorder, the uremic hemolytic syndrome, having to do with some toxins of microbes which affect all vessels, and you see all these hemorrhages here in the pericardial sac. So, if all these vessels, despite how small-sized they are, if they break, a large amount of blood gathers in the pericardial sac, so we have heart tamponade and death. Okay? So this is another form of small pinpoint hemorrhages. These are very big. When they are large enough, they are called ekchymoses. When they are a bit not so large, they are called purpura. In any case, all the hemorrhage is not followed by a loss in Fe, how is it called? Iron. So there is no lack of iron. This is the reason why the MCV of the blood test is not affected. There is no loss of iron because when there is tissue hemorrhage, the macrophages go and take iron, and so iron is recycled. There is no loss of iron, as it would be if we had a blood loss from the patient, if he had a diarrhea with blood, that could not be recycled. It left the body. In this case, any iron that it comes out of the vessels, it is phagocytosed by macrophages, and so there is no problem in the iron quantity. Iron is not lost. What do we see here? A part of this long vessel has been dilated, and so it has made a sac. This is a complication often observed in large arteries which are affected by atherosclerosis, and this is an aneurysm. What's the problem? The problem is that as hemodynamic balance is disrupted in the aneurysm, thrombi can form, and so they may become emboli. And the other is that if the wall of the artery becomes too thin, it may break, and in this case, all the patient's blood will go out of the circulation, and the patient will die. The rupture of the aneurysm, the danger of which is quite considerable, you see, if they are 5 centimeters or larger in diameter, this is a problem, and we must think of surgical intervention in this case, or close follow-up. Have a look at this infarct. It has been formed in the spleen. So some part of the artery giving blood to the spleen has abruptly occluded. The artery's lumen has been occluded. So have a look at the vein. What does it look like? It looks like the one we saw in the kidney. That means it's a pale infarct, meaning that there was no way of another artery sending blood to the infarcted area. So this is a pale infarct. And it was caused after myocardial infarction, because if the left ventricle cannot work well and send blood away, blood stays in the ventricle after the infarct, so thrombi are formed and they become emboli, leaving the left ventricle. And in this case, they have occluded the splenic artery. And we have this infarct. It could form in another way. Do you remember the red blood disorders, one of which is responsible for splenic infarcts due to the problem in the size of the red blood? Do you remember the disease? Sickle cell disease. Yes, it's another case where no thrombi are formed. However, the result is the same, an infarct in the spleen. Have a look at these myocardial fibers. And you can see the substernal chest pain radiating to the left jaw. So there is a pain in the chest, and it radiates to the left side of the neck. You can see that we cannot see the striation of the muscle cells, and we have a cellular infiltrate within the damaged myocardial fibers, and have a look at the nuclei. Identify the majority of these cells. Identify it, please. What cells are they who come there? Of course, you understand that there is some sort of necrosis, of damage, after abrupt occlusion of a coronary artery stem. So what cells come first? When we are very early in the procedure of the infarct. Yes? Neutrophils. So, when the inflammatory exudate is rich in neutrophils, we understand that the infarct is quite acute. If it is hyperacute, they have not come yet. And we just see the lesions in the ischemic myocardial fibers. When we see neutrophils coming, that means 24 hours about after the occlusion of the vessel which led to the infarct. 1 day duration. Here, as time passes and we are about the 3rd to 5th day after the infarct, there are other cells which gradually predominate in the inflammatory infiltrate. Do you remember for our inflammation lessons which cells come next after the neutrophils? Which cells come next? Remember? Who remembers that? First, the neutrophils go out of the blood in the tissues. Then, which cells? The monocytes. And they are called macrophages or histiocytes. However, these cells form there a tissue. Remember how this tissue called when the exudate is organized? This is the inflammatory granulation tissue. And what is there? There is a lack of viable myocytes. That means we see myocardial fibers without nuclei because they are dead and without striation. First, the neutrophils came. Remember what they have in their cytoplasm. And afterwards, the macrophages came, which are phagocytes. This accumulation of inflammatory cells and the organization of the whole area forming the early inflammatory granulation tissue. What makes this part of the heart? With all these enzymes in the inflammatory cells and the dead myocytes, it is very prone, this part of the heart, to have a complication. What can that be? Tearing and eruption, of course. So we are most afraid of these 3 to 5 days after the infarct, because in these days the area is very vulnerable to break. And in that case, all the blood will come out, will have tamponade, and the patient will die due to the rupture of the wall of the heart. Most probably, of course, of the left ventricle. What else can happen? Since the inflammatory tissue logically affects the surrounding myocardium, there the myocardial fibers are viable. They are not dead. So they are responsible for contraction. And so it makes the heart to push the blood away. However, since this is the damaged area and we have the system sending the signals of the heart to contrive, to work, what can this area in the margin of the infarct be responsible for? Because we have many inflammatory cells, and so it cannot work properly. So what can cause? And it can also be fatal to the patient. What can cause? Because the stimulus is not transferred between normal cells. They are viable, okay, they are not dead. However, they are full of inflammatory cells. So what can there develop? And it becomes fatal most of the times. Yes?
Heart block.
Heart?
Block.
Yes, arrhythmias, all right? So the stimuli cannot be properly transmitted, and the heart cannot work on the right rhythm. These are called arrhythmias, and they are very severe, and the area responsible, the histologic area that is responsible for this is this surrounding infiltration of normal appearing myocardial fibers by inflammatory cells. And if the patient survives, the granulation tissue will gradually become what? What does it gradually? Well, first we had the neutrophils, then we had the macrophages. The macrophages excrete fibrogenic factors and bring their fibroblasts. So what is it formed there? Fibrosis, and so this is a scar. This is very helpful for the patient because it has some strength. It's not like the granulation tissue, the early granulation tissue that can break. It has some strength. However, since there is a loss of myocardial myocytes, this part of the heart can become what? There is no longer the thickness of the wall of the heart is short. So what can form there? Because the blood goes and it has pressure. What can be formed in the left ventricles and become full of blood, make a hemodynamic disorder, cause thrombi that may become emboli, and we've already seen that in the aorta. What can become there? As a complication of a quite long-standing infarct, not so recent, sometime. What can become there? Yes? And? This comes early, due to the granulation tissue, the early granulation tissue. If we have a scar and it is affected by the blood pressure, it becomes distended. And this forms an aneurysm, a cavity, an aneurysm. So we have the same problem. And how does the heart work? From the neighboring myocardium, it becomes hypertrophied. So it sends blood. One part of the heart has become a scar, and the neighboring part has become hypertrophied. So this is the cause of arrhythmias due to the surrounding viable myocardial fibers. What has happened here? The patient died of acute pulmonary edema. Why? Because the necrosis of the heart wall extended to this area. Which area do you identify in this image? Which area of the heart is this? Have a look at the valve and count how many cusps you can see. There are 2 cusps. So which valve is this? Excellent. It's the mitral valve. Have a look at the papillary muscle joining the myocardium to the valve. It's the rupture of the papillary muscle. So in this case, the myocardial valve is incompetent. And what does this lead to? The blood, it can send blood to the left ventricle, but a large amount of blood comes back. And where does it go? Pulmonary congestion, pulmonary circulation, and this is acute pulmonary edema due to rupture of the papillary muscle of the mitroid valve. The same could happen if a large part of the left ventricle was necrotic. It could not send blood to the periphery, and the blood would stay and congest the pulmonary circulation. So this is the rupture of the papillary muscle, mitral valve insufficiency. You see the risk. The risk is 5 to 7 days. This is the most crucial period for all these complications to happen. Yes, please. The thrombus has to do with stasis. Stasis. This is not stasis. It's just a lot of blood comes back. So where does it go? From the left atrium to the pulmonary circulation. And this causes dyspnea and edema. What are you saying? What are you talking about? We have not finished yet. There are 4 minutes left.
I was asking you.
Yes. You ask me.
What is the second way of having a pulmonary edema
Apart from the heart? Did I say that as well? I don't think so. Other ways are direct agents, inhaling, having from the air.
No, from the heart. You said 2 ways. One is
of edema. The one I can think is, yes, it's not necessary that the papillary muscle is ruptured. No. If there is some problem in the amount of blood that the left ventricle sends to the periphery, the same happens. Because if it becomes necrotic, then the contraction is not effective. So blood cannot leave the left ventricle. Where does it go? The pulmonary. It's some sort of left heart failure that causes pulmonary edema. Let's have a look at the next images. On a histologic level, when we have edema, have a look at an interesting finding in these ischemic myocardial fibers, that these are, have a look, you see, contraction bands. What do you see in this valve? We have already discussed a similar case. However, the one we have already discussed was not related to infection. This one is. Why is this one related to infection? Because there is a 30-year-old man that took drugs intravenously, so he most easily become infected. These are vegetations. I think they are in the aorta, as if I am correct. And have a look here. You see, this enzyme is elevated. What is the significance of this? When is this enzyme, isoenzyme of creatinic kinase, elevated? When does it happen? When we have the, yes?
Thinking of creatine phosphate kinase with muscle damage.
Damage of the myocardial cells. Yes. How can this be justified? From the inflammation, because this is inflammatory tissue with many neutrophils, because this is bacterial endocarditis, and the inflammation may pass to the neighboring myocardium and affect the myocardial fibers. So they can become inflamed and degenerated, Thus, we have an increase in CK, creatine phosphokinase, the isoenzyme. And due to this procedure taking place in this specific area, with all these large exophytic vegetations, do you remember from anatomy which part of the signaling transmitting system, the stimulus transmitting system, ends there? And how can this be related to a severe disruption of the heart beat or an arrhythmia? It's not, it's the His, the mantle of His. So this patient can have a very severe problem in the rhythm of the heart because all this inflammation may affect His mantle. Another cause of death possible. Have a look at this valve and be quiet so that we finish in 2 minutes. So what is this here? These are vegetations. How many cusps do you see? How many are they? Have a look here. Yes. It could be the aorta then, all right? When we see these vegetations, we understand that an infectious factor has made all these vegetations. And you see now that when we change valves that have a problem, there is a question. Either put a mechanical valve which necessitates anticoagulating therapy, or put a bioprosthetic valve, which, however, may become infected. These are the problems where you have to deal with if you are thinking of replacing a problematic cardiac valve. In this area, which tissue predominates, and how does this lead you to make tell me, when did the infarct happen? Which tissue predominates in this area? Yes?
After granulation tissue. So
it's very late granulation tissue. That's why we have non-cellular areas which are replaced by scar tissue. So this is an old infarct. Would you expect the enzymes troponin and creatine phosphokinase be elevated? No, because this is an old infarct, all right? And it is of interest that we have this image in the heart without the patient having understood that he had an infarct. Why? Because he was diabetic and there was sensory neuropathy, so he did not feel pain. So the infarct, in some cases, may be silent, and the patient does not understand and tell you that he has a pain in his chest. All right, then. Here is the aneurysm. You see how hypertrophied is the adjacent myocardium and how thinned is the wall where the aneurysm has formed. The blood that is sent to the periphery is very low. Okay, have a nice weekend, and we'll have our next lesson on Monday.
soup.